Welcome, Solomon.
Good afternoon, everybody. Thank you very much for having me here, Johnny. And first, before I even begin speaking, I would just like to say that the inspiration that I get to talk to you about today comes from my supervisor, Dr. Orla Dunn. And I'll mention a little bit more about her, but my experience in the Population Health Fellowship is largely down to her and the great work that she's done for me and on my behalf. I'll just share my screen. Can everybody see that?
That's great, Solomon. Yeah.
Great. So my name, as mentioned by Johnny, is Solomon Lebese. I'm a GP registrar. I'm in my final year, my ST3. I'm currently working at Wincanton Health Center, which is on the far east of the county of Somerset, very close to the Wiltshire border. It is one of about nearly almost 20 practices at the moment that belong to the Symphony Healthcare Services Group. And my host organization during this Population Health Fellowship is Somerset County Council. I'm part of the second cohort of the National HEE Population Health Fellowship, and it's going swimmingly well at the moment. I'm learning so much, but you can also see that I've got a bit of an icon of where I studied, which is Walter Sisulu University in South Africa, and it's just to give you a little bit about background about myself. My journey spans 5 countries, 3 continents. And when I started medical school at Walter Sisulu University, they have a very strong emphasis on community health and family medicine. So my journey has actually gone full circle in medical training, and I'm back to primary health care and now into population health management. I'm fortunate to be involved in this program, and it's one of those experiences where you know what you want, but you don't know what you want until you have it. So I kind of knew I've always had an interest in population health and in primary health care and leadership, but I never knew it until this point when all the pieces of the puzzle started to come together. So I'm really grateful for the opportunity and the experience that I'm getting. I believe that my experience in population health management and leadership and clinical medicine.
Solomon, I think you're on mute.
Yeah, I was just muted there. Thank you, Orla. I was saying that the 3 of them, clinical medicine, population health, and leadership, pardon my slide for the almost childlike drawing, but combine into this place I call a sweet spot. And that sweet spot I call the spot of influence. And I'm really appreciating the opportunity to be working in that space where you can see from a clinical perspective or from a patient perspective the impact of clinical health, and then also a population health approach where you can see it from a community perspective, and then how you can tie the 3 together with leadership and bringing forward a population health approach. And I'm very appreciative of that and very glad for the opportunity. So what have I been doing so far in the program? As mentioned before, my supervisor is Dr. Orla Dunn. And she'll tell you a little bit about herself a little bit later. I'm fortunate that she's on the call today. So there's a bit of pressure as well that comes along with it. But Orla is the CBD lead for the county council. And so a lot of the work that I've been involved in has been around cardiovascular disease, pardon the acronym. And so the first and the biggest project that we've been working on is the library project. And this is a scheme, or starting off with a pilot program at Taunton Library to install the Cato M8 machine, which is a machine that collects biometrics, things like weight and height, and calculates a BMI, calculates a blood pressure and a pulse. And hopefully that members of the public will be able to use the machine, get an idea of their data, and get lifestyle advice, because there's a innovative aspect to this project in that there are health coaches that are based at the library. So members of the public will have access to those health coaches, but also they will have access to lifestyle information from the County Council Healthy Living website. But the whole aim of the project is one is to collect the data and also to sort of decompress primary care, for lack of a better word, in that, in case finding for hypertension, so that case finding is not only done in primary care, but also can be done in the community. And then the members of the public can then take appropriate action depending on what their numbers tell them. So it's just started about just over a week ago. And hopefully we'll be able to get some data about how many people are going to be using the machine. And Orla has actually contacted the manufacturers of the machine to also get some extra data. So we're also getting important information like alcohol consumption, smoking status, and those kind of data that we'll be able to use and get a better understanding of members of the public using the machine. We're hoping that this project will be able to roll out to other libraries throughout the county. And the second innovative part of the project is that those members of the public who have, for instance, have an elevated blood pressure reading will be able to loan blood pressure machines from the library through the library system, so that they're able to collect a week's data of blood pressure readings that they can submit to their surgeries. And that information will be very useful because then the surgeries then can calculate an average blood pressure and then decide what is the most appropriate action for those particular patients. The next part of another project that we've been working on is the Men's Shed project. And again, this is an extension of the community case finding of hypertension. And what we aim to do is to work with the Men's Sheds projects, again, giving them a few blood pressure machines so that they can be able to check their blood pressures in the med sheds. And those that have elevated blood pressure readings would then be able to undertake a series of home blood pressure readings, and then also submit those to their surgeries. And again, have access to lifestyle advice. And the other one is, again, using the M8, the K2 M8 machine, practice-based automated assessment. I'm pleased to say, Orla, this is hot off the press, that I managed to speak to my PCN lead, and they are willing and very eager to participate in this machine, and that is to install this M8 machine in the surgeries, so that every patient that comes in through the doors and is going to have some sort of contact with a clinician will have their blood pressure, pulse, BP, and BMI done through this machine, thus saving patient time, but also hitting that all important cough data that we get all the, every patient that comes into the door gets their blood pressure and weight done, but also it's also going to be beneficial in that they will have access to health coaches right from that information. So health coaches will get involved if they're overweight, will get involved if they have a high blood pressure and direct them accordingly. And the last thing that I've been involved in, and this has been through Orla, I have talked to one of the PCN leads, and I've been asked to join the South Somerset West PCN neighborhood, and working on a project of prehabilitation. So there are patients that we all know that are awaiting elective orthopedic operations at Yeovil District Hospital. And these patients often decondition and are usually not optimized enough for their surgery. And this has been worsened with the pandemic, that while they're waiting for their hip or knee operation, their physicality declines rapidly. So we're trying to get a multidisciplinary and involving the community in getting this program off the ground so that we can get them healthy enough so that there are no delays for their surgeries and they're in the optimal condition for their surgeries. What do I hope to get out of my fellowship? I hope to gain a greater understanding of public health, population health management, and the wider system view. I hope to gain an understanding of how to gather and interpret public health data, but also to implement and evaluate population health management projects. And with Orla's Health, where I'm involved in quite a few, so that'll be great to understand that. But because I also have an interest in leadership, I want to gain an understanding on the ICS, because the ICS in Somerset hasn't been formed. The integrated care system should be legislated starting in July. But I want to gain a greater understanding with the hope that I'll be able to contribute at that level in time. and also to build a network with people, like-minded people with interest in population health and leadership. Thank you very much.
Brilliant. That's fantastic, Solomon. Thank you so much for sharing your projects you've been working on and your hopes for the programme. I'd like to hand over just now, if that's okay, then to Sara, who's next. Welcome, Sara.
Hello there, thank you for having me. I'm just going to make sure I can share my screen. So hopefully you can all see that now. So my name's Sara, Harford. It's really great to be with you here today. Thank you for inviting me to speak. I hope it's a really great opportunity for you to all hear about what we're doing as fellows. And very much like Solomon, I'm going to talk about my experience as a fellow so far, what motivated me to apply for the fellowship, and some of the work that I've been doing as well. So just a bit of background about myself to start with. I'm a dentist, qualified about 10 years ago now. I've worked in various healthcare settings, different clinical teams, including general dental practice, hospital trusts, prison, community dental services. And I decided to embark on further postgrad training a couple of years ago. So I'm now currently a registrar in special care dentistry, which is quite a small but developing specialty, which is concerned with the planning and enabling oral health for vulnerable groups, for patients with complex needs such as the medically compromised, those with learning disabilities, physical impairments, learning disabilities, or those who might need conscious sedation or general anaesthetic. So I tend to work in hospital environments and also out in the community, but not in general practice anymore. That's a photo of me in my usual clinical environment, albeit with a bit of extra PPE due to COVID measures. I'm based in the southwest, mainly at Bristol Dental Hospital, but also in the community out in Exeter, Newport and Dorchester as well. And like Solomon, I started in August last year as a National Population Health Fellow. And my host organisation is South Gloucestershire, as part of the Healthier Together integrated care system, which includes Bristol, North Somerset and South Gloucestershire. So why did I decide to apply for the fellowship? Quite a few reasons. With my clinical work, I'm often responsible for treating dental problems that my patients present with, but the majority of them also experience multiple health and also social problems, which clearly contributes to their health and also their well-being. And despite being very aware of that, I've often felt unable to actually address these issues, in part through not having the right skills or knowledge, but also not feeling sufficiently empowered to do that and not knowing how to go about it. I've developed an interest in the wider determinants of health, tackling health inequalities, and it's something I'd really like to get involved with, sort of looking at the bigger picture and seeing how I as a clinician can contribute and help to improve the health of the population that I work for. Often patients present to me kind of late in their oral disease processes, and alongside that lots of medical complexities as well, but also them not being able to access services early enough is quite frustrating, and notice a huge inequality in that. So when I discovered the fellowship, I realised it could be an opportunity, quite a unique opportunity to develop some population health skills, learn about the wider determinants of health, the changing NHS landscape, so the integrated care systems, how they function more widely and from a strategic view, and also how I can get involved. And also with regards to leadership as well, it can often be difficult as a trainee to gain those leadership skills. But they're clearly fundamentally necessary, particularly if you move into a more senior role in the NHS in the future. So far the fellowship has been brilliant. It's been really varied and interesting. We're almost 6 months in now. It's been very busy, but I've been welcomed by my host organisation, and my supervisor is the Deputy Director of Public Health for South Gloucestershire Council. I've been meeting a lot of different people, virtually obviously, from public health registrars, consultants, data analysts, I've also been attending a lot of local authority and system-wide meetings, and just getting to know the system, what goes on and who does what. And that's been a real learning curve for me, as I really wasn't aware of that before. We also have the fellowship workshop days, where we have more theoretical learning and tasks to do between each workshop, but it's a really good opportunity for us as fellows to meet together. And it's kind of a safe space to discuss any concerns that we have, and about our project work, which we are also expected to do as part of the fellowship. So it's been really great to join a kind of community of like-minded and motivated people with a shared vision and passion for improving population health. And in terms of the projects that I'm working on, my first project was the Integrated Care System Outcomes Framework project, and that was where I joined a task and finish group for this. It's essentially a big strategic document, which is a description of the change that the ICS wants to see. It outlines outcomes for what the ICS wants to achieve, and also how they'll be measured. And it's essentially a way of holding the ICS to account for the outcomes over the next few years. Because a lot of these statements, as you can see here, we can write these statements, but actually we can't see or prove that we're making a difference, and ultimately that we're improving population health without the data behind it and showing that that's what we're doing. So the ICS wants to measure strategic outcomes, improve intelligence sharing, and carry out more data-driven decision-making. Essentially, my role was to look at the data that we have locally and nationally to match that to the outcomes, to see how we can measure them. Indeed, if there are any data gaps, and what potentially the ICS needs to continue gathering data on. So I was looking at data trends to create realistic goals for the ICS. And some of the data sources that I've put here are ones that I've been learning how to use. I was also working with the public health data analysts who can obtain and work more closely with local data that we have. And also help to develop short narratives for each of those outcomes to explain exactly why we want to measure them. For example, healthy life expectancy or smoking prevalence, so why they're important, and how we want to see those in the future, and how we want to see improvement. Because ultimately the ICS wants to create this framework document for everybody, so that everyone can engage with it and understand it. My next project is one that I'm leading on. It relates to my special interests, and essentially it's the project that I'm now carrying on and managing for the rest of the fellowship. We know that oral health is essential to general health and well-being. It greatly influences quality of life, and data from Public Health England's oral health collection surveys unfortunately highlight that care home residents experience worse oral health than the general adult population, and they also appear to have a poorer oral health related quality of life. There was also a Care Quality Commission report highlighted that showed that there's inconsistent oral care in care homes and an unwarranted variation in the knowledge, training and support for care home staff regarding mouth care for their residents. But NHS England has outlined an ambition for the NHS to strengthen its support for care homes, and there's a national framework document called the Enhanced Health and Care Homes Model, which has an oral health component on it. And this is all aligning with the NHS long-term plan. Essentially, my project is based in the ICS. I know that there are 285 care homes with an estimated population of 6,900 people across Bristol, North Somerset and South Gloucestershire. But actually there's a real lack of data and awareness about what training and support care home staff are receiving to support their residents. So my project is about determining the actions that we need to take to improve the mouth care training for care home teams. So firstly, I've been finding out who the stakeholders are and also some context. So actually what's going on at the moment, what kind of training and support is being received. And my next step is to try and build a more sustainable network of people that are interested in this, and to come up with some recommendations about how we can improve the training for care home staff, and also start linking people together. Because what I'm finding out is that there is actually there are pockets of some really good practice going on, but people aren't connected and aren't joined up and aren't aware of what's going on, even in an area geographically next door to them. So the ambition is to enable and improve mouth care training and support, also to help facilitate the implementation of that national guidance framework, the enhanced health and care homes, and ultimately it's to improve the oral health of the population of the NSSG. I'm also helping to contribute to the wider oral health strategy of the local authority, so South Gloucestershire Council that I'm working with. So I've joined up with the oral health leads and I'm currently helping support their work there as well. So that's really interesting. In terms of my learning, I've learned so much already. It has been a huge learning curve over the last 6 months. Working on the outcomes framework, that was a lot to do with looking at data and the relevance of that, how to collate data and analyse it. And it's given me an insight into system-wide working, so who's who, and who I may be able to keep in touch with in the future with regards to work that I might want to do as a more senior clinician. It's really made me appreciate that improving population health is a whole system responsibility. So health outcomes drive everything that we do across the ICS, and this does need ownership, a proactive focus and collaboration between many organisations that make up the new ICSs. It's been really eye-opening to look at the data and actually see variations in each local authority as well, so between Bristol, North Somerset and South Gloucestershire, which I hadn't appreciated before. So I feel like I'm getting a good overview of the system. It's more clear to me that our current health and care model isn't sustainable, really, and as clinicians we do have an opportunity to work more closely with public health teams and the local and national government on approaches. And here I put the 4 interconnecting pillars of the framework of population health, as I think that's really relevant for us all to understand. So ultimately it is definitely changing my outlook. I'm beginning to look at things through a more population health lens, and I'm trying to work out how that fits into my clinical work and practice and how I'm going to carry on beyond the fellowship as well. A few challenges, there have been some, so learning to look at things in quite a different way. So I'm not now in a clinic each day, I'm in front of a screen managing a busy kind of Outlook calendar and virtual meetings 2 days a week, but it's obviously has its limitations connecting with people virtually. I'm sometimes unsure about who to connect to next and who I might be able to gain insight from to improve my project work. I guess I've also been used to, as a clinician, fixing things and things being fairly cut and dry, and I've had to realise that actually things take a bit of a longer time and you might not have the right answer straight away. So looking at things kind of in a more broader way and also being more patient, because things do take time and connections do take time to make. And I guess I'm also asking, as I said, the kind of question is, how do I embed this into my clinical practice now and also moving into the future? So in terms of future hopes, I'm learning as clinicians that we can all be champions for population health, and I hope that I will continue to be that and be an advocate for population health within the teams that I work with. I'm realising that I do have a broader responsibility and opportunity, and I do hope to embed the skills that I've learned and also to maintain the connections within the ICS that I've made. I do want to be involved in the future in planning more holistic and inclusive health services that are more prevention focused, and to ensure better access to services as well. But for the rest of the fellowship, I'm looking forward to the continued collaboration and the skills that I'm yet to gain. My contact details there if you did have any questions or wanted to contact me afterwards. Thanks very much.
Thank you, Sara. That was fantastic. Brilliant to hear you developed, the confidence and the skills that you said you felt you wanted to develop to work in the space at the beginning of the presentation. And I thought those were some great, really honest reflections, looking for, what challenges may other people that work in frontline healthcare have if they want to get into population health. So thank you for sharing that. I'm a bit puzzled. We seem to have quite a lot of interference on the line. So I can't see that any attendees microphones are unmuted, but perhaps you could just double check for us just to make sure that there's no interference with the speakers, because it's become a little bit difficult for some of the attendees to follow what is being said. So thank you for bearing with us. Our next speaker is Erika Andrews to talk about her experience and reflections. Thank you, Erika.
Thank you, Johnny. Hopefully you can see my slides now. And thank you, first of all, for letting me come and talk about my projects and what I've been working on, and it's great to have the opportunity to share this with you all. What I was going to do is explain a little bit about how I got to this position and how I started doing the fellowship, what I've been doing, what I've been learning from it, and where I hope things will go in the future following on from this. So firstly, I'm a GP, and I just basically got to a point where I got quite frustrated. So I'd been a GP for nearly 10 years, and I kind of was quite keen at that point to develop a bit more of a special interest in something. And equally at that time, I was starting to get really frustrated because the workload was really going up and up and up in general practice. And it just felt like we were firefighting all the time and not actually getting to deal with the root of why people were getting sick and those upstream type factors that we see that our patients are experiencing. And it just really felt like a lot of the time we're just putting sticking plasters on things, and dealing with chronic disease was like putting a plaster on something and not sorting out the problems that were causing it. And also where I work in a sort of market town in Somerset, which is quite affluent, and there was such stark differences that I saw between my patients in terms of health inequalities. So I started looking around for different things, and then public health just jumped out because it ticked all of those boxes and covered all of those things. So I then came across the MPH and started studying for this. But at that point, I'd got this interest in public health, but wasn't quite sure kind of how I could link that all in with primary care. I did apply just over a year ago. I actually applied for public health training, and I was lucky enough to be appointed. But I know we've discussed this before in previous groups, there's big challenges to doing that. And I've got a young family, and unfortunately I didn't score highly enough to get one of the 2 posts that were within a commuting distance from where I live. And I didn't want to sort of uproot all my family and everything to move across the country to do it at that point. So it was just at that point that the Population Health Fellowship came up, which was actually perfect because it meant I could carry on doing the work as a GP, yet still get some experience in public health and get some practical experience with it. So in terms of what I've been doing with the fellowship, my sort of big area of interest was around adverse childhood experiences, which came up as part of my master's. I came across the original adverse childhood experiences study and was quite shocked that I hadn't come across it before, to be honest, with the impact that adversity has on health and the whole range of people's lives. So I had that interest, and then when I started the fellowship, also looking at the local data, and Somerset has really high rates of mental health diagnoses in young people and self-harm rates. I think self-harm are about the 4th highest in the country. So that's kind of where I've sort of focused my attention during the fellowship. So I'm now part of the Regional Adverse Childhood Experiences Steering Group, which is relatively new, and that's working with lots of different groups from different areas. So local authority, public health, schools, education psychology, and to try and develop a Somerset-wide approach to dealing with ACEs. And as part of that, I've managed to have some funding that was actually provided by the Police and Crime Commissioner to go on a training course to be trained to deliver trauma-informed practice training, which I'm about to start rolling out to primary care. So that covers the adverse childhood experiences, but it also covers other things like racial trauma and cultural trauma, all sorts of things, and looks at how we can approach this better in primary care. So there's a lot of it's about communication skills when seeing people that have experienced trauma. So I'm about to deliver that to quite a lot of people in primary care and also all the GP trainees in the area. Then locally in my practice, we've just set up a health coaching pilot for children and their families. So with this, we already have a health coaching model set up, but our health coaches in our practice currently work generally with older people, maybe with complex problems, but not children and their families. And the aim of this project is to support young people and children around general well-being. So with this, I didn't want to just stick to children themselves, because I think it's really important to acknowledge that the child's experiences relate very much to what else is going on in the home. And what we want to do with this is to be able to address all those wider sort of needs, the sort of social determinants of health type needs that families and young people have. So we've got quite a big remit for that in order to be able to do it. And what our health coach is going to do is a lot of sort of signposting people, helping people navigate systems, knowledge about what's available for them. So we've just got to a point where we've just recruited a health coach to do this for 2 days a week, and she's got a teaching background, which is great, because one of the other things that I'm quite keen to do with this is to link in the work that we do in primary care with what's done in the education setting, as most children's mental health support actually comes from school rather than primary care, and it all feels quite disjointed at the moment. So I'm hoping we can do some work with forming better communication links with that. And then lastly, I'm also on a steering group for a transformation project looking at how we can transform services and make them more joined up in a slightly different area in Somerset, which has got quite high deprivation levels, and that's still at sort of, we're still kind of finding our feet with that one at the moment. In terms of my objectives, so as part of the fellowship, I have a learning agreement, and what I've done here is summarise some of the things that that we're looking at for me to have for my learning outcomes. So with those, I've been using data to identify inequalities, and I've got to spend time with the epidemiologist from Somerset Public Health, which has been great, to look at what data we've got, but probably more importantly as well, what data we haven't got and what we don't know and where those knowledge gaps are. I've also been looking at how we can develop services that work well within a whole system. So particularly with the health coaching project that we're doing, it's looking about what we've got and what we've got locally and how we can fit what I'm doing in to join that up. I also wanted to get more experience of developing evidence-based interventions. And one of the big things that I've come across with the health coaching work is, whilst there's lots of evidence for it for having a positive impact in adults, there's very little evidence for it in young people. So that's something I'm currently working on. Alongside, one of the things I was keen to learn about was about how to evaluate what we're doing. So that's currently one of the big areas that I'm working on at the moment for how we can evaluate this health coaching work that we're doing. I also wanted to gain experience of working with professionals from different disciplines. And actually this has been something that's been a really positive thing for me, because I've got to work with people from all different sorts of organisations that I would never have got to come into contact with at all in the past. So from public health to the local authority, all sorts of people. And it's been a really positive thing for me, because I think in general practice, sometimes it feels a little bit isolated and we don't see the wider picture of all the work that's going on in different areas. So it's been a really great thing for me to see that there's lots of different organisations and different people out there that are all sharing this, they've got the same sort of ideas and the same sort of enthusiasm for this work as I have. Another area I wanted to look at was co-production approaches, and I've been able to spend some time speaking with young people locally, and that's been really interesting, hearing about the barriers and the difficulties they have in accessing healthcare. I've recently been talking to some local pupils who are at a boarding school locally, and it's been really eye-opening to realise that they have so many access problems and difficulties in accessing healthcare, just around problems of people needing to know where they are all the time, so they can't just come to the surgery, or if they do want to book an appointment, they have to go through the school nurses and then say what it is they're coming with. And there's lots of challenges with this, because lots of things are banned at school, so if they want to come and talk to us about anything that's banned, they can't. So some of the other things that I was trying to achieve was around knowledge of local services and pathways, and around evaluating services, which I've just mentioned. Also, I wanted to get more experience around the adverse childhood experiences and their impact on health, and strategies to try and reduce this impact. And this is something that I've been working on with a systematic review as part of my dissertation for my course. And another big area that we wanted to look at was around how COVID has affected families locally. And this is particularly important because with my fellowships, it's slightly different to the other two fellowships. But some of the funding for my fellowship has come around looking at the recovery from COVID. This is quite a big area, and I think we're going to learn more and more about this as we carry on doing the health coaching work. And also another part of my objectives was around education of primary care, around healthcare and inequalities, and that's all going to be covered with the trauma work that I'm doing and the inequalities that leads to for people that have experienced trauma. So in terms of the benefits from the fellowship, there's an awful lot of them. We've already had lots of them from the other two fellows, but it's been a really good opportunity to get to work in an area that I'm interested in and have the flexibility to pick sort of an area to work in. I've had fantastic support from public health, and I'm not just saying that because Orla's here, but we have had really good support. Really good experience of working with lots of different teams and networking, educational opportunities, and also the opportunity to develop lots and lots of new skills. There have been a few challenges along the way as well. I think one of the big challenges I've had is around funding for projects. And I think this is probably a reflection of public health more widely as well, because we don't have any funding attached to our fellowship other than the funding for us. We're kind of reliant on trying to develop things that use existing services or things that we can do ourselves. But I think it's been a good experience, and it's one of the things I've been looking at is with the health coaching is how we can get funding with this going forward, then to roll it on a bigger scale. The leadership side of things, I'm not someone who would willingly lead things, but actually this has been a really good way to develop leadership skills in a very supportive way. There have also been some challenges along the way of things not going in the expected direction, but again, this has been a really good learning point because it's helped me to sort of, when things aren't going the right way, to stop, look at where I am with things, look at where we can go, and to sort of learn to deal with uncertainties in developing projects. In terms of where we go in the future, so with the health coaching work that we're doing within our surgery, is that I'm really hoping that we can get some good evaluation data from this, because as I said, there's not much data around it, and it would be really great if I could get some data and be able to share this and increase the evidence base for this. I do hope that we can roll it out further, perhaps across the PCN or wider, so that it goes on to have a more lasting, longer impact. I'm hoping to carry on with the work around adverse childhood experiences, particularly on the county-wide approach. But most importantly, I'm hoping to be able to continue doing some public health work. In terms of how this looks, I've got a fairly open mind at the moment. We'll have to wait and see how things go. But hopefully that we'll continue to build links between primary care and public health, possibly within the ICSs. I'm hopeful at some point we'll be able to get to the point where we have GP extended roles in public health. And I haven't completely ruled out public health training yet either. Thank you.
Thank you, Erika. That was an amazing and impressive number of projects to squeeze into the time that the fellowship gives you. And I just thought it's been fantastic to hear about how the fellowship program has benefited people at various different stages of their career. So thank you for sharing that. I'm going to try and take you off spotlight just now, so thank you. Orla, if I could just pass to you for the last opportunity to speak, if that's okay. And everybody else, thank you for the questions you've posed so far in the chat box. Please feel free to post more, or if you want to pop your hand up to ask yourself to the panel, feel free to do so. Welcome and thank you for joining, Orla.
Thank you, and thank you for the opportunity to speak today. I should just say, I feel, to just clarify, that I haven't paid either Solomon or Erika for their very kind words that they've said about the experiences of being fellows within Somerset. But I have to say it's been great for us too, and we've absolutely gained an awful lot by hosting the fellows. So I'm a consultant in public health. I'm based at Somerset County Council. I've been there for 9 years. My background is actually in health psychology, and I also came from academia, where I'd had experience of running master's courses and doing supervision of master's students and also PhD students. So that's, I think, given me quite a good grounding for being on this side of setting up a training scheme within the fellowships. I'm also the specialty tutor for Somerset as well, so I support the public health registrars on their training programme, and again that's got echoes around looking at how people need to fulfil competencies. I'm our lead for public health intelligence and population health, and how that is moving forwards, and I also lead on cardiovascular disease, which is obviously the links with the area that Solomon is working on. So just as a quick bit of background about Somerset, so as a system, Somerset's quite nice and neat, I think. This is one of the things that actually attracted me to working in the area in the first place. So the local authority, the county council, is coterminous with a single CCG and a single ICS. So that's made us a really nice, neat system to be able to work in. That said, we are going through a real period of reorganisation at the moment. So we are becoming a unitary council. So the county council and 4 district councils are merging. And we're also obviously setting up our ICS, and we've got the legacy of COVID. I say legacy because I am hoping it's a legacy, but I think we're actually still dealing with a lot of it as well. Somerset is a relatively affluent place, so we have good health. However, we've also got little pockets of deprivation that can often get easily missed because of that general air of affluence. We have relatively a much older population, so that provides a bit of focus for some of our areas and some of our particular health challenges. And we also have challenges because we're quite rural. So oftentimes when we look at how things have been done in more urban environments, it doesn't really quite translate to parts of Somerset where, for instance, we haven't even got an internet signal, let alone regular bus services or means for people to easily access services. So that's all some of the context within which we work. We currently have 3 fellows on the go. So you've obviously heard about Solomon, who is with us for 2 days a week, and he's part of the National Population Health Fellow Scheme. And then we have Erika and another fellow, Deb, who are both with us on the Primary Care Training Hub Fellows. Everyone seems to be called Population Health Fellows. And they have 1 day a week to work on their projects. And I think that's quite tricky, because I think obviously trying to fit progress into 1 day a week is really difficult in comparison to 2 days a week. Solomon's fellowship is fully funded through the national scheme, and with Deb and Erika, we use part of the national funding which was available, and we also top that up with comp money, which is the Contain Outbreak Management Fund. And so this means the projects have had a focus on population health, but also they've been able to support us in understanding the impact of COVID as well. And I think it's been helpful having 3 fellows on the go, in that the fellows have all been able to learn from each other, and in particular when setting up the learning agreements and crafting that documentation, that's been really helpful to be able to have people to link with. In terms of meeting the different competencies for the types of projects and the different fellowships, obviously we've got specific projects which have been generated to support each fellow's area of work. We've needed to be really flexible with those, because often opportunities that we thought the system was offering us to work on a particular area have disappeared, or new opportunities have arisen. So that's had to be fairly flexible, but we have got key areas. So Solomon, cardiovascular disease, hypertension; Erika, work on children; and Deb's work is around older adults and medicines management. Excuse me. As a supervisor, I am directly supervising Solomon, and I'm much more tangential to Erika's work and Deb's work. So we've definitely found it useful to draw in other members of the team. So we've got subject matter experts on child health and older adults who are able providing the supervision for Erika and Deb. We've also got links to our expertise on behavioural health, and also on data, because that's really trying to underpin the population health aspects, so drawing in our epidemiologists and trying to look at the data within the system. The fellows vary in terms of the way the projects were set up. So the topics for Erika and Deb very much have been driven by them, and we have tried to flex our meeting of their desires and their areas of interest to support that work going forwards. The work with Solomon, we had to generate a topic area for him to work within as part of the application process. So that was much more sort of set from the very start. But again, within that, we've still needed to be flexible because some of the work we've wanted to do hasn't been available initially, and new opportunities have arisen that we've wanted to take advantage of. So from our sort of supervision side of things, we see the fellows as a real key part of our population health strategy for the ICS. So part of that is around informing the system of the data and sharing the evidence and building the capacity there. I have to say that bit has been slow progress, not in any way a reflection on the work of the fellows, but really just where our system is and the fact that we are at a fairly early stage, I feel, really, in terms of bringing together our data across the system to try and take advantage on that from a population point of view. We've also wanted to connect the system to work on population health management. And from that perspective, I think having somebody as a trusted voice, so somebody who's, shall we say, the other side of that population health, public health fence, who's actually in practice, I think that has been really, really powerful, and that's been a great advantage to us. Having that person with that insight on the other side has also been really key to making the projects progress. And so, for example, where we've wanted to design interventions to improve population health, in the past, we've sometimes had challenges in not being able to engage the system to work on the projects that we're interested in, and having the insight on the motivators, the drivers, and often it comes down to the finance implications for other parts of the system. That's really helped us to progress those areas of work. And we've also been able to build on the really deep passion of these individuals on working in their areas. And then our final part of our population health strategy is really to support the system and to leave a legacy and also train up the system more broadly to work on population health topics. Excuse me. And I think from that perspective, I think having the population fellows, once we come to the end of the year of their fellowships, we are looking forward to having that legacy of somebody embedded within the system who is going to, we can't really stop them, they're just going to carry on with the good work that they're doing and the progress that they're making. So from that point of view, from a system, it's such a great investment of time to put in to get somebody started and working on those areas. So we've seen amazing work on all of our population health fellows. I think I wanted to just cover some of the challenges for us. So from the supervision perspective, there's sort of doing that flexing of people's interests and the system's capacity to deliver the project. I've put down that keeping up with them has actually been a bit of a challenge for me. Thankfully, I only really have to keep up with Solomon, but you can probably tell that that's a challenge in itself because he's fizzing with ideas and we've done so much good work and made so much progress. But fitting that in, along with trying to deal with the day-to-day work plus COVID, has been really difficult. And I'm actually looking forward to, say, hopefully taking COVID off the to-do list a little bit. Obviously, we've got an awful lot of work to do on the recovery from COVID, but I'm hoping that that will help us to be able to do some more work there. For us in Somerset, I'll hold my hand up. Lack of the population health data to support the project areas has been difficult. And I think that's part of the progress we want to make with those fellowships, is identifying where we have the gaps in the data and how we can improve that, although we have made really good progress on them. As a very practical area, having access to shared space to support cross-organisational work projects was a silly but annoying detail for us. Obviously, we're on separate systems, so we haven't been as easily able to share documents and pieces of work that we've been jointly working on. So if somebody's in that same situation as us, I would say just get that one sorted out early. And I think the lack of time for the fellowships, I mean, we could easily have used these guys full time on each of their project areas, but particularly for Erika and Deb, who are trying to fit their work into 1 day a week, you have to be incredibly creative and disciplined in your use of time, and also making sure that you don't try and fit too much in at once. So in terms of the future, for Somerset, it's been amazing having the 3 fellows, and we've already expressed an interest in both of the schemes for next year. And we've also managed to create other funding within the system to have another separate standalone, possibly 1 or 2 people fellowship, looking at another area of cardiovascular disease. So we are absolutely sold on the value of fellowships across the system, and very keen to be able to carry that on in the future. Thank you.
Thank you, Orla. Really grateful for you sharing your reflections on the programme, and also complimenting the fellows, each from their perspective, we've given this afternoon. If people are still able to stay for a little bit longer, then we're going to have a short time for some questions and answers. We've got a few in the chat box already. Feel free to post some more if any come to mind just now, or if you did want to pop your hand up and ask the question yourself, that's also by all means a possibility. The first question I was going to take up then was from Katie Rose Cawthorne, that I thought would be a good place to start. And I hope you don't mind, Katie Rose, I'm going to slightly build on your questions a bit. So Katie had asked, could the fellows explain how the application process for the fellowship works? And I just wonder if I could add to that perhaps any kind of advice or tips for anybody on the call or is listening back to the recording on what they would say to build or improve their application. Would any of you guys like to take that up from the fellows side of things, perhaps?
Yeah, so shall I talk about mine first? Because I suspect I think the application process was probably different for the other 2. So mine was sorted out by our local GP training hub. I was aware of the other one because I'd looked online for it, but I wasn't, because I'm not in training, I wasn't eligible for that one. But I'm sure they'll tell you about how they applied for that one. But mine was pretty much through word of mouth, that I knew it was coming up, and then applied through the training hub, and it was advertised as well via our local LMC. Don't know whether one of the other 2 would like to say
any
about
advice for writing the application itself, or?
Do you know what? I can't actually remember what I had to put on it, in all honesty. I think for me, because it was quite helpful because I'd already got the interest in public health, so I could demonstrate quite easily that I'd got that interest with the masters and things that I'd been doing around that.
Thanks, Erika.
Yeah.
Solomon or Sara, was there anything you wanted to add at all?
Yeah, I'd be happy to share just one aspect of the application. Part of our application process was to develop a public health intervention or program or project, sort of, and propose it. So that was good. I did a bit of research when I had to do that on what others had done, and what was out there in terms of a public health offering, and how you would actually submit that proposal to higher offices to get it approved. And that was part of what I had to do for my application. I found that quite useful. But as Erika had mentioned, I am a trainee, I did have access to this national program and 2 days. But I also believe that you don't have to be exclusively a trainee. We do have other fellows who are in substantive roles and not in training as part of the program.
That's brilliant. Thank you, Solomon. Sara, looks like you wanted to come in.
Yeah, so for me, it was quite different. I spotted this on NHS Jobs. I think it was around kind of April, May time, and there was a contact email of who is now my supervisor. So I actually just emailed her to find out a little bit more about the role, and we spoke over the phone, and that was really useful. I looked into sort of population health and what's happening at the moment, a little bit of background of the new integrated care systems and reorganisation. And like Solomon, as part of the application, you have to deliver a short 5-minute presentation during your interview about a intervention. So you've got to plan that and propose it, but you are given topics. I think there were 5 or 6, and you can choose one. You've got some time to research it and come up with that. The King's Fund website's really good in terms of finding out a lot more about what's going on in population health, and that helped with regards to preparing for the interview. But I think the most useful thing was speaking to my supervisor beforehand. And I also got in touch with one of the fellows from the previous cohort, because I think we're the second cohort for our fellowship, and they had a pilot cohort last year. So there will be a website with our projects and who we are and our details on there. So I'm also happy as I put my email down if anyone's got any further questions about applications. So I think speaking to someone who's been through it is, yeah, that was the most useful thing for me, I'd say.
Great, thank you, Sara. Thank you, everybody. If I take one of the questions next, then if that's okay. Susan had asked, how has the pandemic response affected how these projects have progressed, or mobilizing the training itself? Did any of the 3 or the 4 perhaps of you have any kind of comments on that question at all?
I think in all honesty, it's been okay. I haven't had any particular sort of hindrance due to the pandemic. And I think perhaps the move to everything being online has actually been quite helpful for me, because it's, especially with only doing 1 day a week, that I'm not spending lots of time traveling as well to get to meetings and things. So actually overall, I don't think it's caused too much problem for me personally.
I think from my side, I've just mentioned the capacity really from within public health. Obviously, we've had a lot of day-to-day work managing COVID and processing cases and outbreaks and situations. So that's made a big difference. But in some ways, it's been really lovely to park that to an extent and have a bit of a break and do something different. So from my point of view, it's I think made it much more challenging to do things, but also made it nicer to do stuff. And we're also very much looking at the recovery from COVID and how the population health work can feed into that. So that's been a helpful progress area really for us to be able to be ahead.
That's brilliant. Thank you, both of you. Susan had also asked to find out a little bit more information about oral health work in care homes. So I don't know if it would be okay if Susan got in touch with you over email just to get some more information around that. But would that be okay?
Yeah, definitely. Yeah, please do feel free to contact me. It's quite a big project, and oral care and care homes can take 2 different paths. It's the delivery of dental care by sort of dentists or health professionals, and then there's also, which is more the focus of my project, it's about actually supporting care home staff to enable oral care on a day-to-day basis for their residents. So depending on what the questions regarding, yeah, do feel free to contact me, but just to kind of check that is the understanding of what my project's about, not necessarily the delivery of dental care, which is something I do clinically, but this is more to do with supporting and empowering care home staff.
Thank you. That's brilliant. I'll let Susan be in touch if she needs to. There was a question from one of our co-chairs, Catherine Thomas. I was going to pop that to Orla, if that's okay. Catherine was asking Orla, is there a national set of competencies for the population health fellows that they have to achieve?
Yeah, so I'm not sure which one came up with the competencies and then which one borrowed it, but yes, we've got competencies for each of the different types of fellows, and I think Erika alluded to it, they both fellowships have to put in a learning agreement and get that signed off as well to show how the different experiences, not just kind of doing the project area, will sort of enable them to achieve those competencies by the end of it.
Brilliant, thank you, Orla. I hope that's answered your question, Catherine. And then Butchie finally has asked to everybody really, if any of you had any good examples of good community outreach during and after COVID. They've commented that in North West London, they've got some good programs on digital inclusion, diabetes prevention. Is community outreach something that's come up in any of the fellows projects so far? Any of you? Solomon?
Yes, one of the projects I'm involved in with South Somerset PCN is a healthy weight management and rehabilitation program. I can't say it all the time, but we've worked with and are working with community groups. So at the moment, we've just included schools, secondary schools, the religious fraternity as well. So it's trying to make it, represent the community as a whole. So everybody involved in this type of project. And I think it'll reap benefits because, like you say, it's going to have everybody to straddle everything, not just the NHS, not only just public health and the council, but all community organizations and individuals with interests.
Thank you, Solomon. I'm going to leave the questions there, if that's okay. And I'm going to hand over in a second to Catherine, who I think want to talk about the special interest group in a second, which will hopefully answer Hazel's question. I just wanted to thank the speakers for attending. I think it's been a wonderful set of presentations. It's really inspiring to hear, despite a pandemic, there's been such efforts to really build a population health workforce. And it'll be really, really interesting over the next few years to see what this huge new body of people with new skills and knowledge, ideas and passion, I think, how they work through the health system itself to deliver change. So thank you, everybody. Catherine, I think you wanted to comment on the special interest group and talk about our next meeting.
Hi, thanks, Johnny. And it's lovely to see so many people here who we have not met before. So you're all very welcome. And it's brilliant to hear about the population health fellows and the kind of explosion of interest among the workforce for population health. And maybe COVID, that's one of the silver linings of COVID. It's got many more people thinking about inequalities and population health and how you do things strategically and going on that journey from one-to-one clinician to a more strategic role. So just to say that Johnny does a fantastic work of regular webinars on behalf of the Special Interest Group for Public Health and Primary Care, which is part of the Faculty of Public Health. And most of our membership are people working in primary care who have an interest in public health. There's a small number of us who are dual accredited, managed to get on the specialist register for general practice and population health, but also we've got members who are not GPs and the wider primary care workforce. So I popped it in the chat and I think Johnny's put it in again. If you'd like to join the group, and it's really kind of for mutual support, information sharing. So things like this we picked up through the group, the population health fellowships and the variety that there is, and trying to find out what everybody is doing and what the opportunities are, and getting support for finding a career through this, which is all a bit of a messy landscape. So if you would like to join, if you go to the Faculty of Public Health website, the links are in the chat, but if you just go to the website and look under special interest groups, you can find out how to join, or just email me. Theoretically, you have to be a member of the faculty, but that only costs you £82 a year, and you get a bulletin and you get access to Faculty of Public Health events, which is really useful if you're interested in population health. So you are all very welcome, and the more the merrier, and sharing knowledge and sharing support is the real point of the group. So Johnny, thanks for organising this, and thanks to all our speakers. I'll hand back to you to close the webinar.
Thanks, Catherine. Sara, Solomon, Orla and Erika, we're so grateful for you sharing your time today. If you were able to send across your slides from the presentations, we'll pop that on our website alongside the webinar. We'll be sending out a link when it is live and available to watch back, particularly if you wanted to share it with any colleagues that couldn't make it today. Our next webinar will be on Wednesday, the 6th of April, 12 o'clock, with Professor Hazel Genn on health justice partnerships, a model of bringing together legal aid clinics, solicitors, lawyers, and those working in primary care to address access to good law services, and how that can benefit potentially primary care, particularly in areas of disadvantage. Thank you so much, everybody, for joining today. It's been great to have your participation, your comments, your questions, and we look forward to you joining the next webinar and hopefully getting more involved in special interest group. Many thanks. We'll pop out a link to the register for the next webinar in the follow-up email to this event. Otherwise, if you don't get a link, please get in touch. Many thanks, everybody, and look forward to seeing you soon. Bye now.